Don't guess. Read EKGs with confidence. This is the EKG breakdown that I wish I had much sooner. Imagine you're going to somebody's house at 2 a.m. They're calling for chest pain, and when you arrive on scene, it's symptomatic bradycardia with a 3rd-degree heart block, and you only knew this because this is what they told you at the hospital, but on scene you didn't know what to do, what medication to give. This is exactly what happened to me. I froze up while the family was crying. I froze up while the EMS supervisor was there. And I don't want that to happen to you. So stay tuned to this video. I'm going to tell you what to do and how to do it. Check it out. Alright, so let's talk about how. How do you read EKGs so good that you don't have to guess and you can read with confidence? It's very simple. You need to understand how something works when it's working normally so that when it's working abnormally, it makes better sense and you could recognize it immediately. While becoming a doctor, this is exactly what they taught me, and I want to explain it to you because a lot of times in medic school, in EMT school, they just tell you this is what you're supposed to know and just kind of leave you in the air. But in this video, I'm going to break down to you the most important information that'll help you make a lot of sense out of this. So the first thing we need to understand and consider when we talk about EKGs and reading rhythms is the anatomy and physiology. How does the heart really work? What are the structures in the heart that I need to consider? How does these structures affect the EKG rhythm that I see on the monitor? Then after we have the anatomy and physiology, we got to also think about what happens when things go wrong. That's pathophysiology. How do the diseases of the heart or the diseases that a person may be suffering from can be reflected on this EKG rhythm? I want to give them the right medication, but I need to know what's going on first and why it's happening. And that's why I'm also going to explain to you in this video what medications to give and when. This is the pharmacology. When to start a line, when to give a sublingual medication, when to do what you need to do and what you were trained to do so you can save somebody's life. Now, how does this start? After we have all this information, we have to be able to recognize what are normal rhythms and deadly rhythms. In this video, another thing I want to do is teach you exactly what you need to know as far as the high yield rhythms, because there's rhythms that are very, very important for you to dominate and others that are good to know versus need to know. Now, the first thing we need to consider when we talk about this subject is action potentials. Action potential, if you remember from A&P, you got electrons and electric energy coming in and out of the phospholipid bilayer by the sodium-potassium pump, and you got calcium, sodium, and potassium. Well, guess what? These action potentials that you learned about in paramedic school need to be considered when you talk about the medications, when you talk about the diseases like hyperkalemia. Remember, hyperkalemia is high potassium. And at the action potential for these different cell types, because when you think about the heart, you have you have electrical action potential and mechanical action potential. And in these cells, what you need to understand is that there's certain electrons that are being shared and going back and forth. We don't want to get into it too deeply. But at the end of the day, the action potential is something that you need to review. But in a nutshell, remember the cell has a phospholipid bilayer where you have calcium that's good for contraction, and you have the sodium-potassium pump. And in the heart, you have two types of action potential, which is the electrical and the mechanical. Electrical for the automaticity and the mechanical for the muscle itself. And here's a fun fact. Once again, in case you didn't know, I've said it in this YouTube channel before, please remember your heart is the most important muscle in your body. Now, when we talk about this important muscle, we need to consider different structures. As you can see on your screen, you have the SA node, you have the right ventricle, you have the right ventricle, the right atria, then it goes to the pulmonary circulation and it comes back into the left atrium, into the left ventricle, and it eventually goes to the systemic circulation, which is your entire body. But for that to happen adequately, you need to have the intervention of the automaticity that goes from the SA node. It starts in the SA node into the AV node and so on. Now, when we talk about this electrical conduction, look at your graph right here. You got the SA node. Then you got the internodal pathways. You got the AV node right here. Then after the AV node, here you have a left bundle branch, and then you have a right bundle branch, and then here you have the Purkinje system, and then the left posterior fascicle. So the anatomy of the heart needs to be considered, especially when we talk about SVTs, heart blocks, and etc. Let's continue. Here is EKG paper. If you want to learn how to read EKGs, we need to go through the basics. And one of the basic things we need to consider is how many seconds or how much time is the value of each small box, and then how much time is the value for all 5 boxes. And notice this axis is actually measured not in seconds but in millivolts. Why? Because the power of the contraction is on this axis, and the time that the contraction or the cardiac event lasts is on this axis. So I just want you guys to kind of just situate you on what's happening here first. Remember, the power of the contraction is here, and the amount of time it lasts is here. Now, each small box is 0.4 seconds, and 5 boxes is 0.2 seconds. And check out, each box here is 0.1 millivolts. And these millivolts will be very important for us to consider when we're trying to diagnose heart pathologies like ST elevation MI. Now, here's a fun fact for you. In case you didn't know, and you're most likely new to EMS, you're most likely having not much confidence with reading EKGs, make sure that when you do print out a rhythm, you count for 6 seconds. 1 Mississippi, 2 Mississippi, all the way to 6 Mississippi, because at the end of the day, the most accurate rhythm is the one that you can read for long enough, and it has to be a minimum of 6 seconds when you're instructed by your clinical preceptor, your field training officer, whoever it is. They're going to most likely want a rhythm that is at least 6 seconds long. So save some time and go ahead and count it to 6 seconds before you finish the printing on the monitor. Now, here we have what I was telling you about before. Check it out. Notice the P wave, notice the QRS, notice the T wave, and this is something called the isoelectric line. The isoelectric line is very, very important because, once again, if we have ST elevations, this is something that we need to consider, because the millivolts, notice the millivolts right here, as I mentioned before. And if you notice, there's a 0 right here and a -5. So it's -5 because it's below a 0. Notice here, right? And then notice the times. Just take a time. Pause your screen, do whatever you need to do, and make sure that this does not go over your head. Now, each one of these has a very, very specific anatomical importance that I will get into, but let's keep it at this for now. You have your P wave, then you have your PRI, which is your P to R interval. You have your Q wave here, you have your R wave there, your S wave here, your J, and then you have your T wave here, the isoelectric line, and the U wave there. And notice the times. So let's go on to the next. Now, here's a video of an actual printout from an EKG. When you print out EKGs, make sure you reference this table on top of me so that you know exactly the calibration that a monitor should be on to be considered accurate. All right, my people, I've created this table for you so that you can see that on EKG paper, there's many things going on simultaneously. It's not just a squiggly line on EKG paper. go ahead, take a screenshot of this table and study it, notice it, link it to what you learned in anatomy and physiology. I don't want to go over it because it'll make the video an hour plus long. I just want to give you the information you need so that it makes sense for you. Because at the end of the day, the more you understand something, the easier it is to remember. So go ahead, take a screenshot. This is not taught this way in anything that prepares you for the National Registry or anything along those lines. So go ahead and study it, and hopefully this will make it a lot easier for you. Now, when we talk about heart rhythms, we have slow heart rhythms, and these are the ones we're going to start with. And these slow heart rhythms create a domino effect in people's blood pressure, in people's mentation, and people's need for ALS interventions or BLS transport. So let's start with the slowest of all the slowest rhythms. And that's asystole. That's flatline. This is not shockable. If you find a patient in asystole, the odds are that this patient has been in cardiac arrest for quite some time. If you find a person in asystole, it doesn't mean that you can't save their life, because I've had patients who were in asystole or pulseless electrical activity, and right when I was calling the doctor to call the end of our efforts, they went ahead and got their capnography up to 30 to 40, and we ended up transporting the patient at a nursing home because we thought that she was not viable, but she actually came back to life, and we got a return of spontaneous circulation. So asystole gives a person in cardiac arrest a bad prognosis, but at the same time, work them up anyway, because you never know. Now, when we talk about asystole, what can we say? We can say that there's basically nothing going on in the heart, not mechanically or electrically. That's why you see, remember, the line here is representing what is going on in the heart. And here you can see this is nothing, which is an absolute indication for you to go ahead and start CPR, unless there's a contraindication for CPR, like, for example, rigor mortis. Now, when we talk about asystole, this is the treatment that you want to give them besides the high quality CPR. You also want to give epinephrine 1 milligram every 3 to 5 minutes, either IV or IO, of a 1 to 10,000 solution. Check the rhythm every 2 minutes. Of course, intubate this person, and of course, follow your local protocols. Remember, this is a YouTube video that is supposed to guide you, but follow the ACLS, AHA guidelines, follow your local protocols. And remember, do not defibrillate these patients, because I've seen people in ICUs, residents and doctors alike, make really big mistakes, and you don't want to be one of those people making the mistakes. So when you see asystole, always understand you want to focus on the H's and T's, like hypovolemia, hyperkalemia, like what caused this issue for these people. But you don't want to waste too much time confirming the rhythm. You don't want to waste too much time in between switching CPR providers. If a person gets tired, just continue to give high quality CPR and avoid the mistakes of thinking that something's wrong with the monitor. If you don't get no pulse and this person's in cardiac arrest, then by all means just start working them up. Now remember the H's and T's: hypovolemia, hypoxemia, acidosis from hydrogen ions, the hypo and hyperkalemia that I mentioned, hypothermia. When we talk about the T's, tension pneumo, the tamponade, toxins, thrombosis, trauma. When you got a person in asystole or a person in any cardiac arrest, you want to consider how you're going to help them best. Now, when we go on to the next rhythm, we talking about sinus bradycardia. Now, what do you see here? One of the things that you can appreciate here is that the P wave is normal, the QRS is normal, and the T wave is also normal. But one thing we do see here is that there's a lot of large boxes in between this R wave and that R wave. And at a glance, right away, you'll gain experience. Like, it's going to come a time where you just look at it from afar and you already know what's going on. But please just take a look. The morphology of all the waves, it's normal. What's not normal here is the distance between one R wave and the next. So, when a person has sinus bradycardia, in the majority of cases, this is normal. Think about an old lady with a pulse rate of 56, or a person that's an athlete who is used to running marathons. Their heart rate will also be below. Remember, a person's normal heart rate is from 60 to 100. If you have a 58, that doesn't mean you gotta start an IV and start giving atropine into this patient. People get treated with atropine and pacing when there is a need. And how do we know there's a need? Is when there's symptoms. That's why they call it symptomatic bradycardia. So what you're seeing here is normal P waves, normal QRSs. The QRSs are not wide, and everything is showing to be from a sinus origin, and that's obvious by the upright P wave. Now, remember, if there's no symptoms, there's no need for acting. There's no need for medications. Now, if there are symptoms like altered mental status, signs of shock, low blood pressure, and etc., one of the medications that we can give this person is atropine, 0.5 milligrams via IV push. There's other things that we can do, like transcutaneous pacing. We can give dopamine. We can give epinephrine. There's so many other things, especially at the hospital, that could be done to help out these patients. But in a nutshell, the majority of sinus bradycardia patients that I've seen have never been treated by me. You just give them comfort treatment, take them to the hospital, because in the majority of cases, like I mentioned, this is not something that requires immediate intervention. Now, on to the next slow rhythm. So, now let's look at the P wave. It's the same process every single time. Let's look at the P wave, the QRS, and the T wave. Now, also, remember, we got to look at the large boxes. So here I see 3 large boxes, basically 4 large boxes in between, more or less, in between each R wave. And what sticks out to me the most is the distance between the P wave and the R wave, or the P wave and the Q wave. Notice how long it is here, how long it is here, but it's normal. It's not abnormal, and that is one of the only things that could be mentioned here. So that leads me to think there's a delay and not a drop in the beat. That leads me to know that this is definitely not a 2nd degree or a 3rd degree heart block. But what I do see is that there's somewhat of a partial block, which is most likely benign. Benign means that there's no need, there's no symptoms related to this. And this could be found in athletes, in older adults, and people taking beta blockers, calcium channel blockers, digoxin, and in most cases, this is asymptomatic. And you know, as I mentioned before, a person who is asymptomatic requires no treatment. Now, when do you treat this person? When they're dizzy, when they have syncope, which means they fainted, when they're hypotensive, when the block is worsening, or when there's a higher degree of a block. And what treatment do we give? 0.5 milligrams of atropine. You monitor, you transcutaneous pace if necessary, and whatever the cause is, go ahead and try to remove that cause from this person. The R to R is only one box, then you can go ahead and think to yourself, the heart rate is around 300 beats per minute. If you have an R wave here and then here, only two boxes in between R waves, then you can go ahead and think that the heart rate is somewhere around 150. If there's three boxes, then you can go ahead and deduce that the heart rate is around 100. If there's four boxes, 1, 2, 3, 4, then you could deduce that the heart rate is around 75 beats per minute. So on this particular sinus bradycardia, you're seeing that there's one box, two box, three box, four boxes. So we already know that this heart rate is below 75. Now, if there's five boxes, then we can go ahead and know that the heart rate is below 60. If the heart rate is below 50, then you'll see six boxes. So let's count the boxes. One box is a heart rate of at least 300 beats per minute. Two boxes is 150. Three boxes is 100. Four boxes is 75. Five boxes is 60. And six boxes is 50. So we already know that based on the fact that there's six boxes in between the R and the R on this cardiac cycle here and this cardiac cycle there, we already know from a glance that this heart rate has got to be below 50. And let's not forget to consider what's in between the beginning of this box and the R wave. So there's 2.5 plus 1 here. It's basically almost 7 boxes in between the R and the R. So the heart rate, it's obviously below 50. And that's how, at a glance, you're able to recognize how fast or slow a rhythm is going based on what I just shared with you. So I hope that helps you understand that. So when we talk about second degree type 1, Winky Bag Mobitz 1, just look at the P wave here, here, and here. Notice how it's progressively getting longer. Example, you have a P wave, then you have another one. Notice the distance. Here, let's call it a first degree block. Then from here on, it's way bigger than the first degree block. And then what you could expect on the beat that is not reflected here is that there is a drop. So do not let this confuse you as it has confused me in the past. It's very, very simple. The P wave gets longer and longer, and then it drops. Once again, if you want to diagnose a second degree type 1, the best way to diagnose this is to understand that it basically look at the P wave, notice how it goes longer, drop. Now, what ends up happening is basically what's going on here is that there's an electrical delay in the AV node. This is usually benign, it's usually temporary, and this is very common in athletes. And whenever there's like a vagal tone dominance and meds like beta blockers and digoxins are being used by the patient, and only treat this person who has second degree type 1 if they're symptomatic. And if you must treat them, start an IV, give fluids, especially if they're hypotensive, treat their syncope, do a 12 lead. Now, so for the treatment, atropine 0.5 milligrams, transcutaneous pacing, once again. Now, when we talk about Mobitz type 2, notice that the PR interval is normal here. It's normal here, and then all of a sudden, there's a drop. Boom. Normal, normal, normal. And then all of a sudden, most likely what you'll see is that there's a drop. So what I want you to notice is that the difference between type 1 is that type 1, the P wave, the PRI gets progressively longer, and then there's a drop. Here, the PRI is normal, and then all of a sudden, there's a drop. Remember, this is the ventricles contracting. And all of a sudden, there's no ventricle contracting. there must be a block somewhere. Now, where is this block? This is a serious conduction issue that is below the AV node. This is in the bundle of His, in the Purkinje system, where this ventricle contraction is being blocked. The person can have a lot of issues, for example, including but not limited to a reduce in cardiac output. This could go ahead and progress into a third degree block, and this can also progress into a cardiac arrest. So when you see these patients, be sure to recognize it, take their vital signs, do a 12 lead if you have time, and skip the atropine, because here the atropine will not be effective. Most likely these patients are very symptomatic and you got to go straight into transcutaneous pacing. Start a dopamine IV drip after starting the line and transport this patient to the hospital immediately and give a notification. And when you give a notification, remember to go ahead and share the person's age, how you found them, what's going on, or what is your presumptive diagnosis. The how you found them goes more in the paperwork, but what's your presumptive diagnosis, their vital signs, your ETA, and let them know that they're being paced actively. Now, be sure not to confuse with type 1. Remember, type 1, you can give atropine. With this one, you don't have to give atropine because it will not work here. And if you notice, the type 1, the PRI gets progressively longer, but here the PRI is normal and there's all of a sudden a drop. Make sure early recognition is very important here, and make sure that as well of the early recognition is that you give transcutaneous pacing and rapid transport. So when we think about the third degree heart block, what are we seeing? Think about it. Remember, we said 6 boxes is already bradycardia. Think about the amount of boxes that you see here. So if we're looking at this morphology, let's say they're looking at it, you get a static EKG and you get this strip in a test, you get this strip in somebody's living room, and you don't know what to, just think about what I'm trying to tell you. There's no correlation between the P wave and the QRS. Ooh, that's not good. Think about the automaticity. Think about the mechanical action that's going on in the heart. It's all out of whack. Think about the amount of large boxes that there is between R waves. 1, 2, 3, 4, 5, 6, 7, 8, 9 R boxes. Or sorry, 9 boxes in between R waves. You already know that this patient's heart rate is somewhere between 20 to 40. This is not compatible with life. Expedite transport. Start expediting zapping these people with transcutaneous pacing. Start a line, give a notification, and this is how you recognize a third degree heart block. Now, normal sinus rhythm. This one's easy. This one everybody knows. Now compare the normal sinus rhythm. Remember, for you to understand how something is when it's messed up, you must understand how it's supposed to work normally. So what we see in this strip here is a normal heart. Notice P wave, QRS with the T wave. This is the isoelectric line. Call this right here the isoelectric line. Everything is flowing smoothly. Everything's working good. You don't have wide QRSs. You don't have a long PRI. The T wave is not peaked. This is totally normal. I'm pretty sure you know this already. But once again, if we want to look at the boxes, 1 big box, 2 big boxes, 3 big boxes, 4 big boxes. This is a normal heart rate. Everything's on the up and up. Now, let's go to something a little bit more exciting. When we pace patients, notice that is what is going on in the screen here. There's mechanical capture and electrical capture. Remember, my people, I told you there's 2 action potentials. With the transcutaneous pacing, what we're doing is trying to synchronize them through a demand pacemaker. And this is actual footage obtained. If you look at the dates right here, you'll see this is a medic partner of mine who I requested they make a quick video of them playing with the pacer. Now, this is by far not the only information you need. Play with it. Ask your preceptor to teach you. If you're in school, learn it, because it's very simple, and the best way to learn it is with a monitor itself. So let's get out of the slow lane and get into the fast lane. Imagine rushing to the ambulance call when this person has VTAC. It says that he's at an urgent care center and the person has VTAC as per the ER doctor treating this patient in the urgent care. You rushed over there just to find a person needing your help and immediate transport. And what I want to do now is explain to you what to do and how to do it for fast heart rhythms. So these patients, remember, it's mostly benign. You do not cardiovert them. You do not give them adenosine. It's most likely caused by fever, pain, like a trauma patient who, let's say, cracked an ankle or twisted an ankle. These types of patients are the ones that you're going to find with sinus tachycardia. And for them, you don't give any cardiac meds. Now, when we talk about SVT, what you can see here is that at a glance, this is already less than 2 large boxes. Once again, my eyes go straight to the amount of boxes in between the R and the R. And remember, SVTs are heart rhythms above 150. And we mentioned that one large box is 300. And if you have two large boxes or less, it's higher than 150. And that's what we're seeing here. Now, this is a regular rhythm. Notice that the distance between each R wave is normal. It's the same distance in between all of them. And the QRS is also narrow, because when we get into fast rhythms, one of the things that we need to look at as well is the length of the duration of the QRS. In this case, these QRSs are narrow and it's regular. And if we're thinking irregular, I'll show you what rhythms that'll be shortly. But this is very, very classic for SVT. And the people who suffer from SVT could be people that suffer from heart problems unbeknownst to them, and it just started with this, or it may have been triggered by some kind of drug or too much caffeine or too much stress, and they're having a panic attack, but that panic attack actually went from being a sinus tachycardia to a supraventricular tachycardia. And if they're symptomatic, what will end up happening is they will start presenting with signs and symptoms that you need to treat. And what I do with patients that have SVT, I give it a second. I check to see if I can talk them off the ledge, for lack of better terms, and see if that meditation session that I mentioned earlier would work on them. And if it doesn't work on them, then what I do next is I start an IV. I give adenosine 6 milligrams followed by 12. Now, here's a fun fact about the adenosine. You have to make sure that you give it as close to the heart as possible, because it has a really short half-life. Now, reassess the patient and be sure to cardiovert them. Once again, follow your local protocols, whether it's 50 joules or 100 joules, but you're going to have to cardiovert these patients if they're showing to be unstable. So if they have 160 heart rate and a blood pressure of 70 over palp and their AMS, then by all means, cardiovert them. And be sure not to confuse SVT with sinus tach. Now, when we talk about AFib is irregular. If you look at the distance between the R waves, once again, this is where my eyes go immediately, it's totally irregular. The easiest way to remember things, then this will help you prepare for the NREMT, or if you decide to go to nursing school, PA school, or medical school like I did, you need to make links between one piece of information that you learn and the next one, knowing that it's not the same information, but kind of making a link between that information and this information. So the way I look at the third degree heart block and AFib is that they're both irregular, and it kind of makes it easier for me to remember. And I hope that helped you. Now, if these patients, because there's people that have AFib and they walk around with AFib and they're taking medications at home, amiodarone and all these other medications, and you may not need to treat them. So remember, treat the patient, not the monitor. If you see an AFib with a heart rate of 145, you may not need to treat them. But if you see an AFib at a heart rate of 170 and they're symptomatic, then we're going to go ahead and give them medications. Then we're going to go ahead and take it from there. But remember, treat the patient, not the monitor. But definitely use the monitor as a diagnostic tool. So what we're seeing in the AFib is there's nothing regular with the distance in between each R to R. Notice here it's almost 3 boxes. Here is 1 box and change. Here is 1 box and change. Here is 2 boxes plus. Notice that there's no correlation in between the R waves. Now, what is happening here? The atria is fibrillating. It's quivering. It's shaking. And then the blood has the tendency to pool. And when the blood pools, the clotting factors come into place and the blood can clot. And that's why people that have AFib are more prone to having a stroke or a heart attack. Because atrial fibrillation, there is pooling of the blood within their atria. This is very common in patients that have heart failure, elderly patients, people that went through surgery, and drug and alcohol abuse. So another long distance cousin of AFib is pretty much A-flutter. Now, this is diagnosed or read a lot easier by noticing the seesaw pattern on an EKG. Odds are this will come out in your examinations for the NREMT. So just recognize a seesaw pattern is something that is characteristic for A-flutter. Now, the risk of a stroke is still high in these patients, very similar to AFib. And the medications that they receive are also very similar to AFib. And these patients as well should receive synchronized cardioversion if they are symptomatic. Now, this is VTAC. These patients definitely get shocked. Notice there's no P waves. And why do they call it V? Because it's originating in the ventricles. Why do they call it TAC? Because it's super duper fast. Notice there's no P waves. And this is a perfect example, a textbook example of what VTAC looks like. The rate will be very, very fast, and the person can or may not have a pulse. So there's VTAC with a pulse and VTAC without a pulse, which is basically cardiac arrest. So when we talk about ventricular rhythms, these patients are very, very sick. If you have VTAC with a pulse and the person's unstable, then you go ahead and cardiovert them. Now, when we talk about VFib, ventricular fibrillation, this person's in cardiac arrest and they need to be defibrillated. Start a line, start an IO, give epinephrine, start working up the ACLS protocol on this patient because this is completely chaotic. And what you see is, once again, there's no correlation between anything. This is just squiggly lines on the EKG paper, and any rhythms that are originating and manifesting in this way from the ventricle and it's fibrillating, it's also a deadly rhythm, and this person is in cardiac arrest. Now, when we talk about torsades de pointes, this is another rhythm that you could expect in your national registry exam. The way I make sense of it, it's basically these patients need magnesium sulfate. These patients also have a rhythm that, to me, the way I remember it, is a combination between VFib and VTAC. VFib, VTAC. If you want to recognize torsades de pointes right away, high yield information, High yield means information that you're most likely be tested on, and it's good to remember if you encounter it in a real life scenario. Tersaz de points requires 2 grams of magnesium sulfate, and it's a combination between VFib and VTAC. And in these patients, you want to be sure to start CPR immediately. Most likely, they will be postless. Most likely, there will be bystanders there. And you're supposed to start ACLS procedures immediately. Now, when we go into knowing your tools, I want you to be familiar with what's within your bags. How can you help somebody if you're not familiar with the tools that are available to you? What you see here is an oxygen bag, a response bag, and a cardiac monitor. This is what it looks like nationwide, specifically in New York City. Now, let's move on to 12 leads. This is typical 12 lead placement, and this is a very recent 12 lead done on an EMT. Just want to show you what it looks like more or less, and let's get into reading electrocardiograms for the 12 lead EKG. Now, the EKG paper once again needs to be considered. The amount of time is what we put the most emphasis on for the 3 leads, which are the ones that we just went over, the slow heart rate and the fast heart rates. Now, when we talk about ST elevation, that information is also very important, but we also think about the millivolts, not just the seconds, but we talk about the millivolts. And remember, the millivolts are also a measurement of energy. And what is energy? Energy can be considered a contraction. Remember, the action potential of the heart is not just electrical, it's also mechanical. And the waves that are going up, if you notice in the previous slides, the P wave is smaller than the QRS. That's because the amount of millivolts needed to make the heart contract is a lot higher, and that's why that spike is higher. So when we talk about 12 lead EKGs, it's good to make sure you guys have that part clear. Now, another thing I want to mention is when we talk about old ladies, before we get into reading the EKG, they present asymptomatically. If you have an elderly female, if you have a person who is complaining of chest pain and they're diabetic, remember that their nerve endings are being affected by the viscosity of their blood, and they may be presenting with atypical signs of a heart attack. I've had female patients that were elderly that they're like, my stomach is hurting. And then when we do the 12 lead EKG on her, we came to realize that she had a massive myocardial infarction for the first time in her life. So please understand, here's a quick tip for you. Patients that are elderly and or diabetic, especially females, present asymptomatically for cardiac events. Now, what is a 12 lead? A 12 lead, the way I look at it, is just basically showing you a person's heart from so many different angles. Very, 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 very useful tool that will help you understand what is going on with a person's heart. The 12 lead gives you a lot of information, but in a nutshell, what I want you to realize is that it allows you to look at a person's heart from many different angles. Now, this is the typical printout of a 12 lead. We have the 2, the 3, the 1, the 2, the 3, the AVF. We have V1, V2, V3, V4, V5, V6. Let me tell you what I see. V1 and 2, think about Sally. V1 and 2 is S. So that's S for Sally, S for septal. This is showing you the septal part of the heart. V3, V4, that is A for apple in the Sally, or A for anterior, the anterior side of the heart. The V5 and V6 is the L. This shows you the lateral side of the heart. And 2, 3, and AVF show you the inferior part of the heart. So if you have elevations in V1 and V2 on two contiguous leads, these are contiguous because, so basically contiguous leads is V1 and V2, V3 and V4, V5 and V6, and 2, 3, and AVF are contiguous leads independently. So once again, Sally, septal, anterior, lateral, inferior. So if we look at a ST elevation MI represented here, we have the isoelectric line. So you have the P wave, you have the QRS, and for some strange reason, this is not where it belongs. This is considered to be an ST elevation MI. Remember we mentioned the millivolts, and each one to almost 3 millivolts of elevation. This person's having a massive MI. As long as they have more than 1 millivolt elevation in two contiguous leads. So what I mean is, this would not be diagnosed as a cardiac arrest unless you see this on V1 and V2 simultaneously. Because if you see it on V2 and V3, the odds of that happening are very slim. But if they were to happen, you would have to consult with your online medical control to see how they want to go ahead and interpret this. But if you find it on two contiguous leads, then that's an automatic indication of a ST segment elevation MI, a STEMI. And if it happens in V1 and V2, that's a STEMI in the septal part of the heart. If it happens in V3 and V4, that's a STEMI in the anterior part of the heart. If it happens in V5 or V6, that's the lateral part of the heart. And 2, 3, and AVF, then that is the inferior part of the heart. Now, one thing I want to share with you guys is you'll have a normal ST segment. Look at the isoelectric line. You have the ST segment elevation, as mentioned before. And then you can have also the ST segment depression. Now, another thing I want to tell you is there's something called a STEMI and non-STEMI. So go ahead and take a screenshot of this table, where it will help you understand the difference between both. Now, moving on to the next slide. This is very similar to what I just told you. V1, V2 septal, V3, V4. And another thing I want you to realize is that, as mentioned previously, there's a lot of things going on simultaneously. So another thing I want you to consider is what anatomical structures are being affected when a person has an MI. So we have coronary arteries that feed the heart exclusively. And if we have an MI in the inferior part of the heart, then the coronary artery that will be affected will be the right coronary artery. So here's a buzzword for you. If you have a test and they ask you which coronary artery is affected by an inferior wall MI, it's the right coronary artery. Please remember cardiac anatomy. Now take a picture of this slide as well in case you're having a problem with 12 leads, and internalize it. I could explain it to you, but what I want you to do is understand it for yourself. That way you will be more apt to get the right answer on the test, and also treat the person that you have in your care a lot better, because I won't be there with you. Now notice and make sure to understand as well when to do posterior leads and when to do right-sided leads. So posterior wall MIs, this is where you put the electrodes. And why would you do it? Think about what I mentioned earlier. V1 and V2 is septal. V3, V4 is anterior. Remember the Sally that I mentioned? So if this is the front of your heart and you're having a heart attack in the back of it, then you will see depressions here, reciprocal changes in the septal. So if you see depressions in V1, V2, and V3, which is representing the front of the heart, then along with that depression, you have upright T waves, then go ahead and suspect or go ahead and do a posterior MI, do posterior leads, put V7, V8 as you see here. Now, if you see elevations on one of these leads of 0.1, 0.5 millimeters or more, then that confirms a posterior wall MI. And this may also be seen in patients that are suffering massive heart attacks. And why is this so important? Because the posterior MI is often missed. A lot of paramedics, a lot of EMTs don't go the extra mile to do this. So if you're seeing elevations of V1, V2, V3, real quick, help the patient out, do everything you got to do, expedite transport, call, but go ahead and do the back leads, because basically, once again, what you're doing is checking to see if the anatomy that is being reflected on the EKG can be confirmed by moving the lead. So what I'm trying to say is the infarct, the ST elevation is demonstrating and manifesting that if something is happening to the anatomical structure of the heart. So by having an elevation or a depression, that confirms that something's going on in that part of the heart. And if you have reciprocal changes, which means one is elevated on one side and decreased on the other, if you have it decreased on V1, V2, and V3, then go ahead and do the back leads or do the posterior leads to check to see if the person's having a posterior MI. I hope that makes sense. So there's a possibility that the heart may be having an infarction or ischemia on the right side. Your heart is the size of your fist, but it doesn't lay in your chest this way normally. It kind of lays at an angle. So sometimes you need to move the electrodes to the right side if you're suspecting a right-sided MI. And how can you suspect it? If you have confirmation of an inferior wall MI, then go ahead and do the right-sided leads before you give nitroglycerin. Because when you give nitroglycerin decreases the preload. And remember, the right side of the heart is preload dependent. So if you decrease the preload and the person's already having a hard time by having ischemia, by having an infarct of this muscle tissue on the right side, and you're also giving it less volume, what will end up happening is you will end up doing more harm than good for this patient. So you have to go ahead and put the leads the way you see here. And if you see elevations of 1 millimeter or more on V4R, which is right here, then that is confirmation for a right-sided or right ventricular myocardial infarction. Now, another thing that you're going to run across very much is a right bundle branch block and a left bundle branch block. When doing a 12 lead EKG, you want to look at V1. And in V1, if the deflection is going up as it is here in the red QRS, then that is a right bundle branch block. If the deflection is going down as it is here, it's a left bundle branch block. And remember, I told you, you have to be able to look at things the way it functions normally so you could understand when there is a problem. So if you remember this picture, notice that earlier I mentioned to you the left bundle branch block, or better yet, the left bundle branch. I'm so used to saying it all together that it kind of flows off the tongue. But look at where the left bundle is located, and then look at where the right bundle is located. So that'll help you understand why things may be going on. For example, in a right bundle branch, what will end up happening is a person may be having pulmonary hypertension or pulmonary embolism. And remember, the right side is the side that has to do with preload. Remember, the right side is the side that connects the deoxygenated blood to the pulmonary circulation and then brings it back into the left side with deoxygenated blood. So it's no wonder a PE will be on the right side. So another thing I want to mention is that on the left bundle branch, remember, a myocardial infarction that's in the inferior MI, inferior wall MI, is one of the most lethal because the inferior wall of the heart is one of the biggest portions of the heart. So when we have a left bundle branch block, this can be confused with a MI. So it's good to ask the people, have you had a heart attack in the past? Because this could mimic an ST elevation MI. Of course, you're going to lean on more signs and symptoms, and you're going to contact your online medical control if ever you think that there's an MI going on. But I want you to notice some of the causes of the left bundle branch block is hypertension. It's cardiomyopathy. It's myocardial infarction, because a lot of the myocardial infarctions are taking this is happening in this location right here. Now, let's talk about the Saragossa criteria. All right, so let's go through this real quick. What we're seeing here is the definition of a concordant ST elevation is a ST segment that goes up in the lead where the QRS is also positive. So this is a perfect example right here, right? And a concordant ST depression is the ST segment that goes down in the lead where the QRS is also negative, right here. So talk about concordant ST depression. Remember the little boxes that we spoke about? 5 of these boxes, the millivolts on the way up, or millimeters, it's 1. So 5 boxes are seen here. And remember, the time is on this axis, and the power, for lack of better terms, is on this axis. So for the Saragossa criteria of 3 points, what you'll see is just 1 box depression on a QRS that's pointing downwards in V1, 2, or 3. What will end up happening is this person will get a total of 3 points. And why is it important? Because this helps identify a potential STEMI. And remember, the heart is made out of muscle. Time is muscle. So if you get this patient in the back of your ambulance, you can go ahead and do this criteria on the 12V that you may or may not be a little bit confused on, so that you could go ahead and activate the cath lab and have them waiting for you. Now, when we talk about concordant ST elevations, this is the elevation of 1 milliliter or 1 millivolts or more in a lead with a positive QRS. And that's even more significant because this will give you a total of 5 points. Now, this Saragossa criteria is not something that's used on a regular basis, at least in New York City. I guess it's because of the time and the distance from one hospital to the next, or the patient's hospital, nearest hospital to their home. Everything's very close. So by the time you do all this, you're already at the hospital. But this is something that is good to know, especially if you're working in one of those areas where the ETA to the nearest hospital is 20 minutes plus. So that is the Saragossa criteria in a nutshell. I invite you to go ahead and look at this topic a lot deeper, but this is definitely an introduction to it. So I hope that helped you. I know one of the best parts of the job is actually giving a medication, some sort of intervention that will actually save a person's life. We'll get to that. But first, you got to go through this first. This is the foundation. So keep watching. So let's talk about hyperkalemia. Hyperkalemia is basically too much potassium in the blood. Remember, your kidneys are the person, or better yet, the organ that is in charge of filtering the blood. And if the person is having renal issues, what will end up happening is that the potassium will not be in the urine going to the toilet. It will actually stay in the blood and cause peak T waves, because the T wave is the repolarization of the cardiac tissue. So This is the depolarization and the repolarization, and this is categorized by movement of the potassium ion. So since there's so much potassium and it's not being excreted, you could expect that patients that are not having the ability to excrete this particular ion are patients that have renal failure, patients that missed dialysis. And the treatment for this can be everything you see here, whether it's calcium chloride, nebulized albuterol, sodium bicarb is if the person's acidotic, or maybe just a trip to the dialysis center, depending on whether or not this is a life or death emergency. But at the end of the day, the goal and the treatment for these patients ultimately is to remove the excess potassium. And on EKG, on a 12 lead, this is how you're able to diagnose hyperkalemia. Remember, the action potentials. There's ions coming in and out, and that'll help you make sense of what's going on here. So, when we talk about Wolff Parkinson's White, the delta wave is very characteristic, and what you'll see here, instead of the PRI being normal on the isoelectric line, what you'll see is that there's a notch right here, and that's called the delta wave, which is signifying the abnormality on the EKG paper. So, by all means, I'm not a cardiologist, but I know that there was a time where I used to look at the 12 leads, I used to look at the 3 leads, and it looked to me just like this. And if that is you, that information that I shared with you will help you tremendously in feeling a lot more confident when reading EKGs. Now, when we talk about medications, let's not forget the right patient, the right medication, the right dose, the right time, and the right route are things that need to be considered when treating our patients. When we talk about cardiac medications, of course, we got to think about aspirin. Aspirin is given at 324 milligrams, chewable baby aspirin, and it's basically contraindicated for people that have an allergy. Feel free to take a screenshot of this picture, but I'm just giving you like what comes up top of mind when we think about aspirin, and it's basically indicated for anybody who's having chest pain and doesn't have an allergy or an active GI bleed, because it's a antiplatelet aggregate medication, which basically means it helps avoid having a person create clots. And the reason why this is important is because people that suffer from AFib, for example, atrial fibrillation, they're prescribed aspirin because, like I mentioned before, the fibrillation of the atria causes the blood to pool slightly, and it'll cause for a clot to be formed, and that clot could go to your lungs and cause a pulmonary embolism, or go to your brain and cause a stroke, or it could go to the coronary arteries and cause a heart attack. So aspirin is one of those medications that is extremely beneficial for cardiac patients experiencing acute coronary syndrome. Now, when we talk about nitroglycerin, of course, it's like one of the most prescribed medications for angina and patients having heart attacks. And by the way, if you look at the screen card up here, what you'll find is how to treat pulmonary edema. And nitroglycerin is one of those medications that helps treat pulmonary edema along with ACS. But be careful because it decreases your blood pressure. Make sure you check a person's blood pressure and have a line in place, have an IV in place when you give this medication. Ideally, they're supposed to have a systolic blood pressure of 120 or higher. Make sure that you check this person's blood pressure. Make sure that they didn't take any sexual medications like Viagra, at least 72 hours for erectile dysfunction before that. And remember, this is contraindicated in people that are having a right ventricle infarct, and that's why we got to do the right-sided leads when you have a person who is having a suspected inferior wall MI, because the right side receives the preload. And if you decrease the preload with the administration of nitroglycerin, you'll be doing more harm than good. I hope that makes sense. Now, If you take an adenosine, remember adenosine has a very short half-life. You should start the line as close to the heart as possible, preferably up here. And then when you start the line on this patient, make sure that you flush it immediately, once again, because it is extremely short half-life, and the first dose is 6 milligrams followed by 12 milligrams. And this drug could also be given to peds, so feel free to pause the video and check out that slide right there. When we talk about diltiazem, this is also for AFib, aflutter, and it should also be used in patients with stable SVT. But the dosage is very different from adenosine in that this is weight-based, and it's also IV bolus, and it should be given over 2 minutes. So it's not a rapid push just like adenosine, but it's also used for tachycardia and other cardiac dysrhythmias. Now, remember the action potential that I mentioned, and this is basically a calcium channel blocker. So whatever calcium is moving through the bloodstream, through the phospholipid bilayer of a cell, what you'll see is that calcium is part of the contraction. So if you have diltiazem causing a calcium channel blocking, then you could expect for a reduction of the ventricular rates. And that's why diltiazem is so helpful and why it's prescribed. When we talk about metoprolol, metoprolol is another cardiac medication that's given to patients who are suffering from hypertensive emergencies. There's a mechanism of action of beta-1 blockers. So if you remember, beta-1 for the heart, beta-2 for the lungs. So when you have a test question that tells you beta-2 stimulation causes what? It causes stimulation or improvement of the lungs, respiration. When we talk about beta-1, you have one heart and two lungs. If you want to make it easier for you to remember, beta-1 for hearts exclusively and beta-2 for the lungs as well. Patients that receive this medication cannot receive it if they're in third-degree heart block or second-degree type 2, because at that point, it will no longer help. What atropine is a medication that's considered to be anticholinergic. And remember, cholinergic stimulation causes salivation, lacrimation, and all these things. And that's why atropine is given to weapons of mass destruction victims, because the block of the muscarinic receptors. And one of the byproducts of this stimulation is increasing the heart rate, which reduces vagal influence. Remember, vagal is parasympathetic. And remember, parasympathetic is rest. And remember, resting will lower your heart rate. So a person with a low heart rate, you give them atropine, 0.5 milligrams to be exact, and it would help them for the adults. And in peds, with severe bradycardia, then you give them 0.2 milligrams per kilogram of IV. Now, when we talk about epinephrine, this is the hero of cardiac meds. Why? Epinephrine is given to so many different issues within our body because it's basically adrenaline. You give it for cardiac arrest every 3 to 5 minutes. You give it for people suffering from anaphylaxis or asthma because it stimulates the beta-2 receptors. You give it to people via IV drip in bradycardia because it stimulates beta-1 receptors. So if you're trying to figure out why is epinephrine given in so many different cases, because of the receptors that it stimulates. Basically, there's a cascade, and you could search this up, where dopamine is the precursor of a lot of different catecholamines, including epinephrine and norepi. And that's why once you'll learn in paramedic school that dopamine has a dosage-based effect. So the higher the dosage, the more you could diagnose or deduce where it's going to work exclusively. So with epinephrine being that is derived from dopamine, being that it has to do with cortisol and fight or flight, you could expect it to affect different areas of the body. And that's one of the reasons why it increases heart contraction, blood pressure, bronchodilation, constriction, and it works immediately. Epinephrine is one of those drugs that you don't want to go in service without it because you'll need it. And just a quick reminder, there's 1 to 1,000 and 1 to 10,000. So when we talk about amiodarone, this is another medication that can be given in cardiac arrest, VFib, and pulseless VTAC to be exact. Then it all depends on what's going on. So if the person does not have a pulse, then the initial dose is 300 milligrams. But if they do have a pulse, then it's 150 milligrams over 10 minutes. And basically, this works at the action potential that I mentioned. If you recall, I said at the beginning of the video, if you know the way things work normally, then it's easier to understand why we give medications or why what's going on is going on in the patient. So in this particular situation, amiodarone works at the action potential and it affects the sodium, the potassium, and the calcium channels. And that's why you see that amiodarone is a medication that is highly, highly used. Now, when we talk about calcium chloride is a medication that is given because calcium has a positive charge and so does potassium. So they compete, for a lack of better terms, within the cell based on their charge. And that's one of the reasons why calcium is given to suspected hyperkalemia, because if a person has a lot of potassium and calcium competes and it displaces the potassium, ultimately improving the amount of potassium in the blood. And it's also given to calcium channel blocker overdose, and the dosage is 1 gram, usually given in cardiac arrest scenarios as well, or severe magnesium toxicity. If you give someone too much magnesium, because what is magnesium? Magnesium, you'll see, is a smooth muscle relaxant. But if you give too much, the magnesium will relax the muscle too much. And that's why you got to give calcium, because remember, calcium, you need it for the muscle contraction. Once again, take under consideration what you learned or review what you learned in A&P, and it'll all make sense for you. Now, basically, when we talk about bicarbonate, it's used in some cardiac arrest scenarios, especially when you expect high acidosis in the patient, and it requires in most cases online medical control approval, and the adult dose is 44 to 88 milliequivalents via IV bolus. And this is also indicated in pediatrics. Search your local protocols for the exact dosage. Now, magnesium sulfate is a drug that's given in eclampsia, preeclampsia, even in severe asthma, because once again, what does asthma and eclampsia have in common? The way I look at it, asthma has spasms. Eclampsia or preeclampsia can be affecting the baby because of the simple fact that they may not be spasming, but it's contracting, and both processes require calcium. And remember, I told you that the magnesium competes with the calcium because it has a similar charge. So what ends up happening is if you give the magnesium, it would help them. And that's why it stabilizes the myocardium. It prolongs the refractory period and relaxes smooth muscle, which ultimately causes bronchodilation, and it's also anticonvulsant in OB emergencies. And this medication is also given in torsades de pointes. For cardiac arrest, it's a maximum of 2 grams. And this is weight-based at 25 to 50 milligrams per kilogram IV. Now, norepi, once again, it's like the distant cousin of dopamine, but they're related, and it's the byproduct of dopamine. And so that being said, you already know what to expect from norepi. It helps patients who are extremely hypotensive. think to you. Return to spontaneous circulation. This person's heart was just not working. Norepi is adrenaline. So you give a person adrenaline, they'll become more alert. Their heart will start pumping faster. For a person who has a very slow heart rate or just came back from return to spontaneous circulation or cardiac arrest, better yet, the norepi will help them tremendously due to the stimulation of the alpha 1 receptors, which will basically cause vasoconstriction, increase in blood pressure, and all these things. And this medication is given IV via IV infusion. And the goal of it is to have and maintain the mean arterial pressure above 65. Lidocaine is one of those medications that is also given as an alternative for cardiac arrest. Now it's time for a scenario. Imagine you're showing up to a scene of a BLS calling for ALS, and as you carry your bags and approach the patient, you find the patient laying supine, and as you start checking for ABCs and your partner gets the report from the EMTs, you put them on the monitor, and on the monitor you see this: a person's heart rate at 32. You're on the street corner loading the patient onto the ambulance and the heart rate is not changing. This is what you see on your screen. If you know what this is and you know what treatment to give, go ahead and comment it down below. Let's see if you got the right answer. Now, after watching this video, I know you're a little bit more comfortable, a lot more confident in treating patients with heart issues. And that's what we want. Our heart is the most important muscle in our body. Please take care of your heart as well. Please take care of your health. As first responders, we want to be healthy, so then that way we won't be pouring from an empty cup, and we're able to help our patients because we're able to help ourselves. Remember, on the airplane, they say put your mask on first. So as first responders, if we're healthy and leading by example, that will not only benefit us and our family tree, but it will also benefit our patients because we'll be less prone to drop them. We'll be less prone to be tired while doing CPR. So by all means, take care of your heart health as well by leading a healthy lifestyle. I know it's a lot easier said than done when you're on the road and sometimes the only thing you have to eat is in the drive-thru. But if you need any help, please lean on me. And if you stayed this far, please read what you see on the screen. This is from me to you. May God continue to bless you and yours. And may you continue to do God's work, both with the uniform or even without the uniform. Now, if you like this video, click on this video right here. There's a lot more where that came from. I hope this helps. Peace.